Hello, everyone, and welcome to another episode in our Smarter in Minutes series. My name is Dr. Onyema Ogbuagu. I am an associate professor of medicine and director of antivirals and vaccine research program in the section of infectious diseases of Yale University School of Medicine. I am so pleased to be joined today by my colleague, Dr. Natasha Bhuyan, who is an assistant clinical professor in family, community, and preventative medicine in the University of Arizona, located in Phoenix, Arizona.
Hi, Onyema. Thank you so much for having me.
Now, over the next few months, we'll be posting a series of these short CME-certified videos focused on the management of patients with COVID in the outpatient setting. This activity is jointly provided by National Jewish Health and Bonum CE. This program has been supported by an educational grant from Pfizer. Now, please be sure to let us know who you are and complete the pre-polls in the tweets below or using the QR code showing on the screen. Now, today, we'll be talking about Remdesivir in the outpatient setting for the treatment of mild to moderate COVID. Now, most of you will be aware that Remdesivir is now FDA approved for the early treatment of mild to moderate COVID-19 in outpatients, and is approved to be used in the outpatient setting, particularly for individuals who are non-hospitalized, who have mild to moderate COVID-19 and do have high-risk conditions that put them at risk for hospitalization and death from COVID-19. Remdesivir is an intravenous nucleotide prodrug. It's an adenosine analog that interrupts the activity of remdesivir RNA-dependent RNA polymerase, which inhibits viral replication, terminating the transcription process. And it's approved for the treatment of COVID-19 in adults and pediatric patients aged greater than 28 days and weighing greater than 3 kilograms. Remdesivir is administered initially as a loading dose for adults, 200 milligram on day 1, followed by 100 milligram per day on days 2 and 3, and then with different doses for younger individuals aged greater than 28 days and weighing 3 kilograms to less than 40 kilograms. And these individuals should receive Remdesivir 5 milligram per kilogram intravenously on day 1, and then half that dose on days 2 and day 3. So now, given what we know about Remdesivir, Natasha, would you like to tell us about the clinical trial data that led to this indication for Remdesivir in the outpatient setting?
Yes, this was a pivotal outpatient trial called PINETREE. This was an outpatient study with Remdesivir to assess early administration of Remdesivir to prevent progression to severe COVID-19 disease in outpatients with at least one risk factor for disease progression. And those risk factors were age over 60 years, obesity, or other certain coexisting medical conditions. This was a double-blind, randomized, placebo-controlled trial, and the primary efficacy endpoint was a composite of COVID-19 related hospitalization or death from any cause by day 28. And a secondary endpoint in this trial was a composite of COVID-19 related medically attended visit or death from any cause on day 28. And now the primary safety efficacy endpoint was any adverse event. And people were randomized to receive 3 days of Remdesivir, and that was the 200 milligram loading dose on day 1, followed by 100 milligrams on days 2 through 3, or placebo. And it was 562 patients that were randomized. There was 279 with Remdesivir and 283 with placebo. In terms of hospitalizations and deaths, 2 out of the 279 patients, or 0.7%, in the Remdesivir group, and 15 out of the 283 patients, that's 5.3%, in the placebo group, had a COVID-19 related hospitalization by day 28. And all hospitalizations occurred by day 14. No patients died by day 28. In terms of medically attended visits, they were also lower by 81%. That's 4 of the 246 patients, 1.6%, in the Remdesivir group, and 21 of the 252 patients, that's 8.3%, in the placebo group, had a medically attended visit with a hazard ratio of 0.19, 95% confidence interval, that was 0.07 to 0.56. Now, the changes in viral load from baseline to day 7 it did not differ substantially between the two groups. Now, Onyema, so we know that remdesivir is efficacious in this patient population. What do we know about the safety of remdesivir?
That's a great question. And so we have the data for adverse events in those that received remdesivir versus placebo. And one caveat I'd like to mention here is that remember in these clinical trials that some symptoms or laboratory abnormalities that people may report during trials could be attributable to COVID itself rather than drug. And so with this in mind, adverse events of any severity occurred in about 42.3% in the remdesivir arm and about 46% in placebo group. And if you look at the distribution, it looks like it was pretty evenly matched. The more common adverse events that tended to occur were either gastrointestinal side effects like nausea and diarrhea. There were also some people that reported headache as well, about 6% across both arms, and of course, respiratory symptoms such as cough. However, when you looked at adverse events that were determined by investigators to be related to trial, this occurred in about 12% of those in the remdesivir arm, as against about 9% in the placebo arm. And it was found that fewer patients actually in the remdesivir arm than in the placebo group had serious adverse events. And so I think overall, the data was quite encouraging that remdesivir showed a reasonable safety profile, and very few people actually discontinued treatment due to adverse events, and there were no deaths across the study. So from this standpoint, safety data is encouraging, but we do realize that there are other considerations with using remdesivir, such as drug-drug interactions, certain things to monitor as people are on therapy, and even like special populations such as those with renal impairment. So Natasha, would you like to provide more information around these?
Remdesivir can cause GI symptoms. This can cause elevated transaminases as well as increased prothrombin time and hypersensitivity reactions. And so what we tell clinicians is if you have a patient on remdesivir, monitor the renal function as well as the hepatic function and PT as clinically indicated. Now, remdesivir may need to be discontinued if a patient's ALT levels increase to 10 times the upper limit of normal. And remdesivir should be discontinued if ALT levels are also associated with signs and symptoms of liver inflammation. Now, remdesivir should be administered in a setting where hypersensitivity reactions can be managed. That's places like outpatient infusion centers or skilled nursing homes. And patients should be monitored during the infusion and observed for at least 1 hour after the infusion as clinically appropriate. Remdesivir is a minor substrate of P450 as well as CYP3A4, OATP, as well as 1B1 and B glycoprotein. And so the FDA updated the remdesivir label in July of 2023 to reflect that no dosage adjustment of remdesivir is recommended in patients with any degree of renal impairment, including those on dialysis. So that means remdesivir may be administered without regard to the timing of dialysis. Now, the use in remdesivir in pregnant or lactating patients, it's inconclusive. And so it should be approached by weighing the individual risks and benefits of that patient. Now, the administration of remdesivir in the outpatient setting, it can be challenging due to its IV route of administration. And so, Onyema, are there any treatments on the horizon with oral formulations similar to these MOAs targeting RDRP?
Yeah, Natasha, you're absolutely correct. I think it's kind of logistically challenging to administer intravenous medications outpatient setting, particularly having to do that 3 days in a row, if you will, like is done with remdesivir. And so as you can imagine, rightly, there's interest in thinking about oral alternatives that have a similar mechanism of action. And I think even more critical in the face of emerging variants, because we recognize that even though the virus is going a lot of evolution, that it appears not to be affecting the targets of remdesivir, which is RDRP, such that we expect that those category of compounds should retain activity regardless of variant evolution. And so there are a couple of oral alternatives that are in different phases of clinical trials. However, one I would highlight today is Obeldesivir, which is a prodrug which is actually hydrolyzed and converted to remdesivir triphosphate by a nucleoside kinase. And it has a similar mechanism of action, which is inhibiting the activity of RDRP, which is RNA-dependent RNA polymerase. There's early clinical trial data available in a phase 1 trial that had about 70 volunteers. The PK looked fine, didn't appear to have issues regarding to food or not, that they were able to achieve sufficient blood concentrations, and it also showed an acceptable safety profile. I mean, there were reports of headache among just 2 participants who received Obeldesivir compared to just 1 person who received placebo. And the most common laboratory malady was a little bit of fluctuation in creatinine clearance, about a grade 2 creatinine clearance decrease in about a third of those who received Obeldesivir and 25% in the placebo. So encouraging initial data, and the study has since moved to a phase 3 trial that will be a randomized double-blind placebo-controlled trial with an enrollment that will be almost 2,000 subjects. And their primary endpoint will be the standard endpoint for outpatient trials for early treatment of COVID-19, which would be the composite of COVID-related hospitalizations and all-cause death. You know, enrollment started in February 2023, and we look forward to the results. So, Natasha, we've covered quite a bit in a short time. And so do you want to give us a quick summary of today's discussion?
Yes, the key takeaways from today's discussions are Remdesivir is an FDA-approved treatment for COVID. It's a direct-acting antiviral agent that targets highly conserved viral RNA-dependent RNA polymerase, and therefore it is likely to maintain efficacy against emerging COVID variants of concern. The efficacy and safety established in PINETREE in the outpatients shows that it is safe to use. This can also be used in adults as well as pediatric patients, and oral formulations targeting other RNA-dependent RNA polymerase, the same mechanism of action, are in development.
So Natasha and I would like to thank you so much for joining us today. Please complete the post polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME. Click like and follow for more social media-based CME from Bonum CE.